Hi, it's Dr. Dave McCreary from PEM POCUS UK, and in this short video I'm going to be showing you how I use POCUS to scan for clavicle fractures. Along the way I'll try to answer these three questions. So we know that clavicles are commonly injured in children, making up around 1 in 8 of all fractures we see in the PED. But why not just X-ray? Well, for clavicles alone, POCUS has been demonstrated to be faster, saving time for the patient, and is extremely well tolerated. Often children have minimally displaced injuries in the middle third, requiring nothing more than a broad arm sling and minimal follow-up. But commonly I find myself in this scenario, whereby I'm clinically convinced of a fracture. The X-ray says no, but POCUS gives a clear demonstration of the reason why the child attended. So how reliable is it? Well, one large systematic review of adults concluded a very high sensitivity and specificity. There's been one paediatric study to date, with others ongoing. So how do I do it? Well, for this I use a combination of the high frequency linear probe or the hockey stick probe for smaller children. I'll position myself on the edge of the bed, applying a generous amount of warm gel, especially for little children, looking in plane like this, trying not to turn my head too much, having the machine very close to the bed. Now the clavicle is an interesting S-shaped bone that means it's undulating and you have to follow it all the way. It's also extremely superficial, as you can see, often only a couple of millimeters below the skin. Now we like to try to visualize all aspects of the cortex in two planes, the same as X-ray, knowing that the thinness of the ultrasound beam is less than a millimeter at its thinnest point, meaning we have to undertake various views to capture all parts of the surface. I like to take these three views. Firstly, an anterior view in longitudinal, as shown here. Secondly, we've got a superior view on the top aspect of the cortex. And thirdly, a transverse view, where we're rocking along the bone to visualize this, given this semicircular appearance. So here I'm demonstrating the anterior approach using a large amount of gel. As you can see, I'm following the S-shaped curvature. And then I move to the superior cortex, where we're scanning downward. Again, we're applying minimal pressure. The patient is comfortable all of the time. And then laterally, I move into a transverse view, doing my best to scoop up that gel as I go, because it gets lost as you move around quite a bit. And again, you're applying minimal pressure. We're holding the probe here like a pen or a pencil, with skin on skin all of the time, limiting any pressure for the patient. And what I'm demonstrating now is the rocking motion that you can see, required to visualize all aspects of that cortex when we're in transverse. Here's me using the hockey stick probe, what I'd use for smaller children, perhaps 4 years or younger. Again, gives the similar appearance. You can see that bony cortex, the hyperechoic cortex, is only 2 millimeters below the skin surface. And here's me trying to follow it as best as I can, looking for any cortical deficit, any step, before then moving into transverse, where you get this semicircular appearance with a smooth, broken semicircular line. Again, following that S-shaped curve all the way from medial to lateral. This is the appearance you might get. And what we have to then do is gently rock the probe. So in order to see all aspects of the surface, we've got to get that gel in between the probe and the skin, and we're just gently rocking backward and forward. Again, you see me scooping the gel as we go. And then these are the appearances provided, whereby we get the smooth, unbroken line. At times, what we may need to do is use a hybrid approach, which is oblique, whereby we are midway between a transverse and a longitudinal view, which would look something like this. And I do this in order to really examine the cortex in greater detail and to interrogate that surface, making sure I'm not missing any subtle fractures. This is actually easier than it looks. Here are some examples of clavicle fractures I've identified using POCUS. In this first example, we see a clear cortical step at the medial third of the clavicle. In the next example here, we can see the clear angulation, and this was a middle third fracture. And in the final example here, you can see a clear cortical disruption with a surrounding hematoma, providing further clues that the bony injury has occurred. In all three of those examples, all of the X-rays were completely normal, reported as normal by radiologists, but thankfully was picked up using POCUS. I hope this has been a useful video. For more videos on POCUS, just search PEM POCUS UK on YouTube.